Hello, everyone. Welcome to another episode from our IMG initiative. We are super happy to have you all here with us. This is our first residency program. Join us. We're going to have a few sessions until January, so we are super excited about it. And we have Penn Medicine here, internal medicine residency program. And we have two super special guests, Mark and his partner. Do you want to introduce yourself?
Hey guys, my name is Mark. I'm a third-year internal medicine resident at UPenn. Really excited to present this case. Sorry if I'm a little slow. I am post-call from the MICU right now, so I just woke up about 20 minutes ago. So if I'm presenting the case a little slow, my brain is not working too quick today.
I think anything that slows down your cases, Mark, will be very, very appreciated given how challenging they always are.
Agreed. Hi, everyone. My name's Uttara. I'm also a third-year internal medicine resident at Penn. And I'm just generally slow, so bear with me, even though I'm not post-call.
That is not true. She is an expert future ID doc.
I love it. Thank you for being with us after a post call. So, do you guys want to tell something that you do for fun outside of medicine?
Yeah, I would say, I guess I'll say one thing. You want to say one thing? We love to travel. So we actually recently got back about a couple of months ago from Greece and Istanbul. And it was an amazing trip. Lots of fun, lots of great food, lots of great people. So that's one thing we love to do together.
Yes, and we're also huge foodies, so we love to cook. Philly has some great farmers markets and like amazing restaurants, so if you guys are ever in the area, definitely let us know. We have a whole list of recommendations.
I love it. So I think, can we get the whiteboard and start with the case? Yeah, I think we can start.
Awesome. And I'm even going to present a little bit of data in the first aliquot just because it's a complicated case. And then also I just want to leave some time to talk about residency too. So it's going to be probably a little quicker than normal, but it's going to be a lot of fun. So let me just pull my PowerPoint.
Noah and Marino, while Mark's pulling it up, I would say two of you obviously feel free to take the lead, and I'm happy to fill in any gaps that are left, which I imagine has a low pretest probability. But yeah, I'm excited to hear you all think through it, and we'll get as close as we can together. Our goal is not going to be to solve the case, but we can at least analyze it to the best of our ability.
So we're going to start off in the outpatient hematology clinic. That's kind of where this patient's story starts. So we have a 42-year-old male. He essentially presented to the outpatient hematology clinic with 3 to 4 months of fatigue. And he was found to have a white count of 51,000 with a left shift, increased neutrophils, increased bands, increased metamyelocytes, myelocytes, eosinophilia, basophilia, 2,500 blasts, a white count of a platelet count of 1.8 million, and a hemoglobin of 10.3. And that's where we'll start.
Marino, do you want to start?
Okay, I think I can tackle a bit of this. So thank you for the information, Mark. So it's a little bit of information, so I just want to take it step by step so I can try and tackle everything. So when I see 42-year-old male, 3-4 months of fatigue, increased white counts, and I think I heard 51K white blood cells, also with increased bands, myelocytes, eosinophilia, low platelets, and low hemoglobin, I immediately like to shift myself towards thinking about the fatigue. That is the main concern of the patient, and we have something that we can not like fully anchor on that, but maybe we can think it's the main reason for it, and it's that the patient is probably undergoing with some underlying hematologic issue. So seeing his increased white blood cell count, this is a patient that is really in a concerning status for me, but also when we see patients with increased white blood cell counts, low platelets, and hemoglobin, basically we are in a state of cytopenias, and the cytopenia could easily be explained by his abnormal immune cell response with the increased white blood cell count. So what I'm trying to fit is that this patient has fatigue with a borderline low hemoglobin. So I would expect the fatigue to kick in anemia in patients with hemoglobin below 8 or 9. So I think his fatigue is something that couldn't be attributed 100% to his anemia, but we may have to explore something of it. So I'm thinking about what does this patient could present with this presentation. So this patient is prone to have other infections, or he could be either really inflamed, that is playing the fatigue. But the time course of 3 to 4 months is something that I might need help with all my, oh, I see 1.8 million platelets. Okay. So this is a patient that has a marrow that is producing a lot of elements. So I didn't catch that. But yeah, basically trying to tackle in the fatigue, I don't have a certain cause that I can think of, but basically I think this patient is really inflamed, and we need to look for something further in the history that could help us to think if either he's inflamed or his anemia is the main contributing factor, but I don't think so. So can you help me with it a little bit, Noah?
Yeah, sure. So I actually, when I'm looking at this case, I think from the other side. So I think for me, fatigue falls to the background. Seeing those labs are more concerning to me. So now we have like a middle
I think we may have had Noah. Oh, there we go. You're back now, Noah.
So we have a leukocytosis with lots of cell lines. This really seems to me like CML. We could think of an infection driving the leukocytosis, but this patient would be much, much sicker. It would present acutely like sepsis state. This is like a more brewing progression, and it makes me really anchor on the CML diagnosis. So I think right now what Mark's trying to do is set the stage for us with this diagnosis, and then we're probably going to dive into some other complications. I don't know, Jack. What do you think of this case so far?
I think one of the things that I love about both of the two of yours analyses is that it comes to very similar conclusions from different directions. And I think it highlights the fact that there's no optimal way. There isn't necessarily an optimal way to solve or think through a case, right? We have many different lenses that we can take on different problems, right? Many of us have frameworks or multiple frameworks for how we might think about hypoxia, or multiple frameworks for how we might think through abdominal pain, depending on what direction we want to approach that problem from. And for me, when I see this case, I'm approaching it from the direction of filtering everything through that white cell count and that differential that we see here, primarily because it is a very, very abnormal finding, and some of the clues on the diff that you both have mentioned can help us start to narrow our understanding of this patient's disease process fairly early. There are sort of two variables that I'm tracking in that white count of 51,000. One of them is the degree of elevation that we see, and then the other one is the various types of cells that we're seeing on blast. Right, Noah, you alluded to this, that a white count that is very, very elevated with solely neutrophils as the neutrophils as the predominant source of that white blood cell count elevation maybe makes us think about an underlying infectious picture. But the more that we start to see specific cell lines elevated, the more our calculus starts to shift away from an acute infection In other words, a reactive leukocytosis, and more towards a primary problem in the bone marrow. And if we look at what we see here, we have neutrophilia, myelocythemia, eosinophilia, and basophilia. And as you mentioned, Noah, all of those are going to fall into our myeloid cell line of white cell precursors. So when we see that there's a myeloid cell line abnormality with a lot of white cells in the periphery, right, and this sort of more subtle, slow, indolent course, I think, as you said, Noah, I'm right there with you in terms of getting to the possibility of a myeloid leukemia. Now, myeloid leukemias can be acute or chronic, and certainly the chronic can transform into the acute form via something called blast crisis. And so one of the things that we want to ask ourselves is, are we dealing with an acute leukemia in which we would see a high percentage of blasts in the periphery or the bone marrow, or potentially a chronic leukemia that is transforming into blast crisis if there are blasts that are present there? I may have missed this, or at least didn't track the absolute number, but I think Mark mentioned that there were blasts. And if there's more than 20% blasts in the periphery, we start to worry about either an acute leukemia or a transformation of chronic into an acute blast crisis. But there's another clue on the CBC here that can help us understand the likelihood of an acute versus a chronic myeloid leukemia here, and that is the platelet count. I'll ask the group, if we were to run through our minds, what do we think is more likely to be present in an acute leukemia? Thrombocytosis or thrombocytopenia? Just go ahead and pop in the chat here what you think is more likely in AML or ALL. Yeah, exactly. Thrombocytopenia, right? The white cells are, there is a clonal proliferation of white cells occupying all of the bone marrow, and there is going to be a huge, overwhelming replacement of that those normal precursor cells with these blast cells, and so that's why we can get the cytopenias. Whereas in CML, it's still not common, but more common than in AML to see a very high thrombocytosis. I don't know the exact mechanism, but for me, the idea of the bone marrow slowly churning out a lot of cells slowly over time, for me, tracks with the idea of potentially platelet generation being able to ramp up. And so I think I'm wondering about the possibility of CML here, which, as we were saying, right, can frame for us, one, the possibility of CML transforming into a acute blast phase or an acute blast crisis, and then two, the possibility of understanding this individual's underlying immune system. An abnormal proliferation of white cells is going to mean that there's probably some degree of qualitative underlying immunodeficiency, which we may have to keep in the back of our minds as things unfold. But before we start to think about those things that may be becoming relevant later on, there's one thing that we need to be attuned to right as we talk to this person. And that is whether this amount of platelets is causing, and this amount of white cells is causing a significant amount of problems with things like their peripheral circulation. Right? Platelets play a huge role in clotting. The more platelets we develop, the more likely we are to potentially throw aberrant clots. And so worrying about the ischemic complications of very high levels of platelets in the periphery, whether that is a cerebral ischemia from clots, right, vision changes, or visceral clots that this person can develop, there is a risk of thromboembolic events when platelet counts get very, very high. And so that's another thing that we're going to want to be attuned to, knowing that this person has 1.8 million platelets circulating in their bloodstream. So I think those are the three things where I'm tracking right now, right? Is this AML or CML, as those being the two probable things, with maybe some clue towards CML that could be evolving into a new phase. Number two, understanding that this is a likely to be a relatively immunocompromised host. And then number three, being attuned to the maybe increased probability from the epidemiologic baseline of this person developing thrombotic complications with having platelet counts that high. All right, Mark, take us into what I imagine is going to be another hairpin turn here.
Awesome. So the hematologists agreed with all of your guys' thoughts. So they did some studies on the bone marrow and on the peripheral blood flow cytometry, and the patient was found to have BCR-ABL positive and was diagnosed with CML and was started on a tyrosine kinase inhibitor. So I'll kind of fast forward a little bit. So, the patient, like I said, undergo therapy for CML. And then 1 month after that index presentation to the hematology clinic, he presented with weeks of night sweats, fevers, and his workup really was notable for a CT chest with left hilar and mediastinal lymphadenopathy and hepatosplenomegaly. But, he was out at a neighboring hospital for, about a week. And they couldn't figure out what exactly was causing his fevers and his lymphadenopathy and his hepatosplenomegaly. Infectious workup was negative, autoimmune workup was negative, but he didn't have any new diagnoses for that was given to him. And then over the next 9 months, he had recurrent episodes of fevers, cytopenias, night sweats, hair loss, joint pains. And then he actually received a lymph node biopsy of that hilar node that I mentioned, which showed a necrotic histiocytic lymphadenitis. And he was treated actually with rituximab due to concerns for possible Kikuchi disease. He had a CT chest that then showed widespread centrolobular ground glass opacities, most pronounced in the left upper lobe, some scattered solid pulmonary nodules, some of which were juxtafistural, and they said that also may represent intrapulmonary lymph nodes. Then, this is kind of what he brings to our institution. 11 months after that index presentation, he developed months of dyspnea, cough, and again, recurrent fevers, and he presented to our hospital for further evaluation.
What a banger of an aliquot. Oh my God, so much information, Mark. You really aren't taking it easy with us. So I'm going to start, Marino, and then you can share your thoughts. So right now, what I have is a middle-aged man with CML undergoing treatment. So we can presume he's immunocompromised. That's presenting with kind of subacute to chronic fevers and sweats and weight loss, right? Hair loss, pains, and a reticuloendothelial system activation, right? He has lymph nodes, he has hepatosplenomegaly, he has a necrotic lymph nodes, and he also has some pulmonary compromise. So what can tie together like the pulmonary system and the reticuloendothelial system in an immunocompromised host? Of course, my mind jumped to infections, and given the time frame, I'm thinking more of like opportunistic infection, more indolent infections, like TB, MAC, or some kind of fungal infection, maybe histo, given the pulmonary focus. Histo can infiltrate the reticuloendothelial system and cause some kind of problems there. But right now, I think before diving too deep into my potential differential diagnosis, we're really trying to understand everything that's going on with this patient. And I really don't know if there's an association between CML with possible autoimmune diseases. I think this is a very important branch point for us before like deciding, is this autoimmune related or infection related? Because the treatment for each other is not compatible, right? If it's autoimmune, we're gonna immunosuppress further the patient. And if he has an infection brewing, this can be bad news. So there is my tension point right now. What do you think, Marino?
Yeah, thank you, Noah, for that. I couldn't really agree more with the part of the immunocompromised host and the amount of susceptibility this patient has for opportunistic infections. So I think, like, as we all know, everything that TB causes, histo can cause it better. That's something Dr. Restrepo told us once. So I don't want to anchor that, but the fact that the CT chest and the hilar lymphadenopathy with the biopsies that showed necrotic sites, that always makes me think about first infection and then other problems. So not anchoring on that, but I also wanted to say that first, when I saw the picture and this patient was complicating his clinical course after receiving treatment, immediately my mind jumped the thought about what Jack just told us, that chronic processes like CML can really transform into an acute process like AML. So the picture kind of fits this patient for AML, but the time course is too long, and that's where I am more concerned about something more subacute to chronic ongoing instead of an AML. I'm thinking more about an infectious process, and really more with the opportunistic infections. So I would like to put into consideration, like you said, TB, MAC, histo, blasto, and also about the fever, cytopenias, night sweats, and hair loss. And I think I heard joint pains too. So that made me think about a lot of autoimmune processes, specifically lupus and rheumatoid arthritis. So I don't know if there's a way that CML or the tyrosine kinase inhibitor therapy could correlate and transform into something autoimmune like lupus or rheumatoid arthritis. So when he was talking about Kikuchi syndrome, that's actually a knowledge gap for me. So I might have to deep a little bit more into that to see if it can fit in the picture. So, but that's what I have to add. So yeah, can you help us a little bit more with this?
I don't know how much help I will be, but I can certainly think through it with you all. I think you all frame the problem really, really effectively, which is we are seeing the evolution of a disease process characterized by sort of subacute inflammatory symptoms and B symptoms, cytopenias, maybe some connective tissue disease related symptoms, as well as a predilection for both the lungs and the reticular and endothelial system. And I think it's hard to know which part of that process to focus on. I think if we look at this through the lens of somebody who has known CML and has been put on a TKI, I think you all are both very astute to be focusing in on the possible infectious complications that can arise from someone who has been on a tyrosine kinase inhibitor, and the infection risk goes up quite a bit, both in terms of pyogenic bacterial infections, as well as infections that we may commonly see in immunocompromised hosts, whether that's the endemic mycoses, other yeasts like Cryptococcus or pneumocystis, and then also molds like Aspergillus and Mucor. But if we look at this disease process, right, many of those infections, particularly things like Aspergillus and Mucor, are things that may be limited to the lungs, and this doesn't seem to be a process that is limited to the lungs, given all of the other organs that are involved. If we just talk a little bit about the CT chest imaging here, I think it's striking to note that there are both centrilobular nodules with ground glass opacities, as well as it sounds like nodularity within the fissures. And those can be due to the same process, but there's also the possibility that those are due to two separate processes. Nodularity that kind of goes along the fissures tends to be related to an underlying lymphatic process. Perilymphatic nodules, which we can see in things like lymphoma, sarcoid, and then also myeloid sarcoma, which is going to be sort of soft tissue manifestations of underlying myeloid disease, will tend to disseminate through the lymphatic system and cause a perilymphatic distribution of nodules in the lungs, some of which some of those perilymphatic vessels will line up along the fissures. Whereas centrilobular nodules tend to reflect airway spread of a process that's implicating the lungs. And so seeing the combination of centrilobular nodules and these nodules along the fissure makes me at least think about the possibility of two separate underlying processes here. The hepatosplenomegaly cytopenias, I think you all have touched on that very, very astutely, but I think the primary attention point for me that I'm thinking of is how much of this is related to potential progression or sort of ongoing ongoing manifestations of the CML outside of the bone marrow, right? We can see hepatomegaly, we can see splenomegaly, we can certainly see cytopenias as that disease process evolves. How much of it is from that versus how much of it is from a unifying process that seems to be causing this subacute inflammatory disease? One way to frame it is, as you all were saying, the possibility of an opportunistic infection that has disseminated to all of these organs and maybe got there by virtue of the lungs. But I think also being open to some of these being from the CML, and then some of these findings being from another process that's acquired as a complication of the CML. All right, Mark, take us forward here.
Awesome. Thank you so much for that amazing discussion. So I'll talk a little bit about some more background. So in terms of the past medical history for this patient, he has this history of Kikuchi disease, CML, disseminated VZV at the age of 17, and disseminated MAI infection at the age of 28. He has no past surgeries. His medications, he's on ruxolitinib, dexamethasone, Bactrim prophylaxis, Levaquin, posaconazole, and acyclovir. He has no known allergies, no pertinent family history. And then for his social history, he works as a writer and movie producer. He traveled in the US and to Germany as a child with his father, who was in the military service. He denies any chemical exposures. So talking about his physical exam, in terms of his vitals, his temperature was 102 degrees Fahrenheit. He was sitting at 100% on high flow nasal cannula at 60/60. He was tachycardic to 129, and his blood pressure was 118/91. For the rest of the exam, in general, he was sleepy appearing, lying in bed with his high flow nasal cannula. For his neuro exam, he was ANO times 2 to 3. He was oriented to the year, but not to the month. His face was symmetrical, moving all his extremities appropriately. For his head and neck exam, he was anecteric, oropharynx was clear, his mucous membranes were moist. For his pulmonary exam, he had normal work of breathing, clear to auscultation bilaterally, and he did have some diffuse crackles. For his cardiac exam, he had a regular rate and rhythm, no murmurs, his JVP was not elevated. His abdominal exam was soft, non-distended, non-tender. On exam of his skin, there were no rashes that were appreciated. And then his MSK exam was notable for no joint swelling or any tenderness. And his extremities were warm with no lower extremity edema. In terms of his labs, they were notable for a white blood cell count of 2, hemoglobin of 7.5, platelets of 23. His anion gap was 17, ALT of 246, AST of 151. His alk phos was 229. His creatinine was 0.93 with a BUN of 23. His sodium was 136, potassium of 3.4 with a chloride of 100, calcium of 9.2, a bicarb of 19. His coags were normal and his lactate was 4.9.
Okay, I think I can start with this. It is actually a lot of information, so I'll start first with the information on the past medical history. So looking at the history, what is NAI? I don't recall the abbreviation, so if someone can help me with that. But going down in further into the past medical history of this patient has had severe infections since a young age. So I'm really worried about something, an underlying background of immunosuppressive conditions, such as all of those possible immunodeficiency syndromes that we can get as a child. Also, the patient is on a lot of medications that can further immunosuppress the patient. But I see that he's also in prophylaxis for in case he gets febrile neutropenia for his case. Also, I think I heard in the history that his father was part of the army. So in this patient that is certainly immunosuppressed and can be, and we don't know if he lives with his father could carry diseases back from the army. So it can further predispose him to develop some resistant or rare infections that are not commonly seen in the US. And then going into the physical exam, basically the physical exam confirms that he's widespread inflamed and he has multi-system involvement such as CNS involvement with the AAO times 2, pulmonary involvement, and basically that's it. But he has a really high heart rate, he's on supplemental oxygen, and also his temperature is really above the sky. So tackling in on the labs, the patient is basically on a pancytopenic state, could be secondary to either his previous presentation of CML, AML, or also the treatment he's receiving with the further immunosuppression of rituximab and ruloxitininib. And I think I saw that the MCV was 89, so looks like kind of a hemolytic picture, but what I'm trying to anchor is when I see the AST and ALT of this patient and the alk-phos, I see that there's some reticulum endothelial and also hepatobiliar involvement. So one infection that can cause widespread multi-system involvement, including lungs, spleen, biliary tract. I immediately think about MAC, Mycobacterium avium, even though the patient he has had the infection before, so maybe he could present it right now, and he's also, I mean, he fits the picture and he has the risk factors for it, even though he doesn't have a low CD4 count, and maybe he's more neutropenic instead of lymphopenic. He still could present with that, considering the amount of immunosuppression that this patient has. And also the patient has a high anion gap metabolic acidosis and normal kidney function as far as I can tell. So if you can help me and tackle with it a little bit more now, I will really appreciate that.
Yeah, sure. So I agree with all you said. I think you covered all the main points in the past history. What I'm thinking right now, though, is if I was in the ER seeing this patient, right? I see a patient that's heavy on immunosuppression. He's febrile, he's tachycardic, he has like borderline blood pressures, is hypoxic, looks overall very sick, right? I would want to know what's the differential on his white blood cells, and I would want to treat him for like a possible sepsis syndrome. Like he has like an underlying diagnosis that's causing his chronic symptoms from like 10 months ago. This presentation is very, very worrisome for me. I think this patient is an unstable patient and deserves like immediate care. And then we can think about the differential diagnosis for his underlying condition later. Like further than this, I think you covered it very well. I don't think I have anything to add. What about you, Jack?
Yeah, I think you all, I think, have covered the foreground phenomenally well. I think just, it's difficult to make a ton of progress here at this point in time, but I think that a big frame shift for me was seeing the ways in which there was this sort of history of these disseminated infections. And I think like the first type of infection, or the first, I think, disease that commonly comes to mind in terms of an underlying immunodeficiency that can present or have manifestations that span on into adulthood is something like CVID. But I think it's interesting to note here that if we look at the infections that this person has had, the infections that he has are not the classic CVID types of infections. Those are usually going to be pyogenic bacterial infections, particularly encapsulated organisms that we see flare up over and over and over again. And so I think then if we start to expand our minds and say, well, gosh, there is a predilection here for a underlying myeloid neoplasm. Two, right, if this diagnosis of Kikuchi's lymphadenitis, which can be difficult to definitively diagnose, but right, there was some of the characteristic features of that. So we see a predilection towards myeloid neoplasms, autoimmune diseases, and underlying infections from a very, very young age. It starts to bring us into the possibility of underlying germline or somatic mutations that could lead to abnormalities that don't just extend into the immune system, but into many different precursor cells. I will not pretend to have expertise on like or a deep knowledge base on what these different syndromes are, or what these different syndromes can be. I have experience caring for somebody who actually had one of these diseases, which was GATA or GATA2 disease. And I think the cue there is the disseminated MAC is incredibly relatively common in individuals with those underlying features. But beyond that, I don't have a lot of knowledge here. But I think overall, right, we're seeing cytopenias, autoimmune diseases, myeloid abnormalities, and a predilection for infections that seems to date back to a relatively young age. And so the possibility of this all being an acquired process starts to dissolve a little bit, and the possibility of actually there being some sort of underlying inherited process or something that has actually changed in this individual's DNA or a somatic mutation, which we can see arise later on in adulthood, but can also happen early on in childhood, I think starts to come up. So if anything, what this aliquot helps is to really expand the tempo and the timeline of this disease process and say, oh, maybe actually what we're seeing here is the emergence of something that has been going on for much, much longer. And I think some of those somatic syndromes or somatic mutations start to potentially come into the fold here. But right, we're only going to really be able to think about those or meaningfully diagnose those once we get this individual through this very, very hyper acute phase that they seem to be going through, which in the setting of this underlying immunodeficiency might be very, very tough to support them through, given how severely ill they are already at this time.
Such a wonderful discussion. Is it okay if I share my screen just to show a CT scan? This is kind of the patient's updated CT scan. Like I mentioned, they got that CT scan on their journey to kind of this hospitalization, but they got a new CT scan this submission, which I think is going to be pretty crucial. Let's see. I'm able to share. I'm not too well versed with computers. Let's see.
First.
Mm. 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 Okay. Are you guys able to see this CT scan? Awesome.
Yes.
Would you guys like me to give you the read, or would you guys like to interpret? I'll leave it up to you guys.
I'm happy to share a little bit of what I see, which I will say never send an internist to do a radiologist job, but we do have to interpret things on the fly sometimes. And so I think jumping out here, it seems to be like there are diffuse airspace opacities, many of which look to be sort of ground glass in nature, with also maybe some sort of predominant or some basilar predominant consolidations as well. Maybe there's a pericardial effusion there, but it might just be related to the window. But I think sort of diffuse ground glass opacities, basilar consolidations, and that's about as far as I can take it. Would love to hear more from you, Mark.
Yeah, no, the only thing the radiologist added, so yeah, diffuse bilateral ground glass opacities, but they mentioned very prominent, like intralobular and interlobular septal thickening as well. But yeah, that's exactly, they mentioned the GGOs, like you mentioned, the dense consolidations. I will stop sharing my screen. Okay. Awesome. So now we'll talk about some advanced labs. So the patient got, a broad infectious workup, had blood cultures which were no growth to date, had sputum cultures that were no growth to date, Legionella, strep pneumo urine antigen that was negative, got a beta D-glucan aspergillus antigen that was negative, quant immunoglobulins that were negative, CMV, EBV, VZV quants that were negative, histoantigens that were negative, blasto antibodies that were negative, coccidioides antibodies that were negative, a cryptococcal antigen that was negative. The patient also got an autoimmune workup as well, had an ANA that was negative, an ANCA that was negative, an SSA and SSB that were negative, an RF and CCP that were negative, complements that were normal, a ferritin of 4,900, a soluble IL-2 receptor that was normal, and a TTE, which was also normal. If you guys have any questions on any further labs, I'm sure there's maybe a couple that I missed, but most, all infectious autoimmune workup was negative. But the next aliquot will reveal the final diagnosis.
Do you want to take a stab at it, Marino, or should I?
I want to hear your thoughts first.
Okay, so I think the only thing we have positive so far is the CT chest, right? We have diffuse bilateral ground glass opacities. and this prominent interlobular central thickening. So I remember Robbie mentioning in the past case that this basically means that the vasculature, we have like edema, like vasogenic edema. And since we don't have, the left heart isn't affected by the TTE, we can assume that this is like a non-cardiogenic pulmonary edema. So it can happen in inflammation. It's very unspecific. And we have then like the very extensive infectious workup, all negative, and also the autoimmune workup, all negative. I mean, this patient is a patient that I will definitely be consulting my colleagues, my more experienced colleagues that can help me with this diagnosis, because to be quite frank, like I can see there are many things wrong with this patient, but I really don't know how we can start to tease it out from him. What do you think, Marino? What would you do?
Yeah, I totally agree with you. So I think the only part of workup I don't see is the pneumocystis workup for him, but honestly I don't. I mean, he has all the risk factors for it, and he has the imaging that fits with the diagnosis, but I don't think that will help me explain all the other stuff that he's presenting with. So the reticuloendothelial involvement and everything, but I will still get like a BAL or something that could get us to know, because I think in this case tissue is going to be the answer for him. So, but there's still other infectious etiologies that I think we haven't ruled out yet. So I'm thinking about brucella, MAC, and TB. Those are mainly the ones I'm thinking about. And for the ferritin, the other lab value was a pertinent positive, but expected for him is the ferritin. So it's an acute phase reactant, and he has been inflamed for a while, so for over a year basically. So that's expected on him. But anything else you want to add, Jack?
I don't think I have too much to add. I think I am not sure whether or not to treat the prominent interlobular septal thickening as like a key signal of the underlying disease process here, or something that is coming as a byproduct of many of the other different pathologies that are happening here. I think Noah and Reno, you both have given a fantastic overview of what that is, and I think the sort of categories of disease that are coming up in my head are diseases that can spread through the lymphatic system, right? And if we just sort of run through a general list of that, there are infections that could do it, including disseminated mycobacterial infections, right? Many of those have a predilection for the reticuloendothelial system, as we've said over and over again, which has a ton of flow and support from the lymphatic system. So there are some infections that can do it. There are some cancers that can do it, particularly the hematologic cancers like lymphomas and leukemias, one of which we know that this gentleman already has. And then there's sort of a variety of sort of maybe we would say non-infectious and non-malignant diseases that can do it. For example, amyloidosis can do it. And there's another list going forward there. But I think one of the things that I'm struggling with is the fact that all of the things that are under our consideration right now can cause many of these different constellation of findings. A recrudescence of disseminated MAC, right, given the organ systems that are involved, seems possible. I don't usually think of MAC as having a very, very hyperacute and aggressive course like this, but in the setting of somebody who has this degree of immunocompromise, it certainly seems possible. And so I don't think I have a strong addition to the differential that you all have already laid out here. And so I think really, as you all are saying, right, it'll be interesting to see where the ultimate diagnosis comes from, whether it's something like a bone marrow biopsy and we see a characteristic finding there, an organism that grows from the bronchoscopy, or another one of the pieces of soft tissue that ultimately ends up being involved here. So yeah, I'm super curious to know, Mark, right, kind of how this unfolded, and ultimately like how you all came to discover this diagnosis. I think both the final DX and the most efficient path to that final DX seem like they're both really, really rich discussions to have.
Yeah, and I'll say I only took care of the patient for like 2 days, just on kind of coverage, but I learned a lot from my colleagues by just like discussing through this like interesting case. As you guys, this patient had a few consultants, on board, was started on broad spectrum antibiotics, just given how sick he was in his neutropenia and immunosuppression. But ultimately, he underwent a bronchoscopy. And for the bronchoscopy, it was AFB, fungal, anaerobe, and bacterial cultures were negative. They did a wash that was negative for diffuse alveolar hemorrhage. He had an elevated white blood cell count with prominent eosinophilia, and he also had PAS positive material. So this bronchoscopy was most consistent with PAP, pulmonary alveolar proteinosis, and then he had a lymph node biopsy as well, again, of that a hilar lymph node, and they ran genetic testing on, which they didn't do before, and it was consistent with GATA2 haploinsufficiency.
What an amazing case. And I just need to shout out Curtin that really got it in on the chat, like way back. He's amazing. What are your thoughts, Marino?
Yes, thank you for this amazing case. Actually, a lot of learning for me, but I also have to give Kirtan the shout out. Since the second aliquot, he already knew the answers. I don't know how he does it, but shout out to him. But definitely something I have to read on. I don't even know what is GATA2 deficiency. So, and I didn't expect PAP to present like this. So thank you for this amazing case. And in retrospect, I'm just thinking about the first time I got to discuss and comparing it to this one, and I feel so much improvement in myself. So that's something I'm really proud of. But thank you for showing me this amazing case and having Noah and Jack help me with it. So thank you for it.
Awesome. I cannot applaud the two of you more. Curtin, of course, deserves a shout out, and I agree with you, Yaz. It is never a surprise when he clinches the diagnosis. Yeah, Marino, no, amazing job thinking through this case, right? Just a wall of data to sift through what's signal, what's noise, what's acute, what's chronic, and really how to sort of prioritize both the acute disease presentation here, but also understanding and moving towards something that has been going on for the last 34 years of this gentleman's life in some way. It's a lot of disease to chew through here, and I think you both did an absolutely phenomenal job. Marino, I love hearing the pride. It is well earned pride, and Noah, I hope that you are feeling it too. What I am feeling is just gratitude for the two of you, gratitude for you, Mark, and bringing the case, and also for your partner, who I'm sorry I missed your. I want to make sure that I pronounce your name correctly.
Yeah, it's pronounced Uttara. It's a hard
Athura.
name.
Thank you,
Yes.
Athura, for bringing this as well. It is just such a treat to meet you and to get to see you here. And then Deb and Yaz, thank you for organizing this. This was an absolute blast.
Amazing discussion, Noah, Marino, and Jack. Great case, Mark, as always. I think everyone was scared about Mark's case. And yeah, we have a few minutes and we want to know a little bit more about you guys. I don't know, I want to pronounce your name correct, Uttara. If you want to tell us a little bit, I don't know, about the residency, what do you like most about Philly? There's a question in the chat, if you can tell us.
Yeah. Again, great discussion, guys. And Marino, I had no idea what GATA2 deficiency was either. So there's a lot of learning in this case, something new for me. I feel like I'm, immunodeficiencies in general, something I'm weak on and I need to, grow and learn more about. But yeah, do you want to maybe start talking about Philly a little bit?
Sure. Yeah, so Philly is really such an amazing city. It has something really for everyone. I would say like every part of Philadelphia has its own kind of culture and its own vibe. So we right now are in the Rittenhouse Square area, which has a lot of like really nice restaurants, like a really nice like kind of central park. It has like a lot of like very beautiful like cobblestone streets, and actually we live right on the Schuylkill River, which if you learn anything about Philly, it's that it has a lot of really hard to pronounce names. And one of them is Schuylkill, which is spelled like a crazy, I'll have Mark put it in that group chat, but like you'd never guess it was pronounced Schuylkill. But there's like a beautiful river trail. And you can go kind of running on the trail. There's a lot of like outdoor things to do. Amazing food scene, amazing like arts and culture scene. And then there's a lot of hospitals in Philadelphia. So we're obviously at Penn, but there's a lot of like major academic centers. So everyone is wearing scrubs everywhere. It's like a huge just like medical community, which is really fun to be a part of. I think there's like some crazy statistic that's like 1 in every like 4 doctors in America has like at some point trained in Philly, which is like very cool, kind of to be a part of that. And then I see a question, what is something special about your residency? Which feature do you love the most about it? Ooh. It's hard to answer this question without sounding like sappy or generic, but it really is, I mean, you know, just the camaraderie among the co-residents. Like I, you know, was nervous, you know, that maybe people would be a little bit, you know, I knew I was coming to an institution with a lot of smart people, and I didn't know if people would be like, you know, stuck up in any way. And it's not that way at all. Like everyone is so down to earth, kind, collegial, like, you know, has your back throughout everything. And you really need that in a residency program because residency is hard no matter where you go. So that's been like really, really special to be part of that. I don't know if you have.
Yeah, no, I shared the same worry. I came from a smaller, kind of newer medical school, so I was worried about kind of the same thing, going to kind of a larger academic institution, but that kind of also has a small, you know, family feel as well. I think the thing I also love too is the variety. So we rotate at 3 different hospitals. So we at our main hospital, our academic institution, we see things like GATA2 deficiency and, you know, these crazy, you know, oncology, autoimmune diseases, kind of, you know, rare stuff, and also bread and butter. But then we go, you know, we can walk from our main hub, it's called HUP, the Hospital of University of Pennsylvania, to our VA, almost like a 10-minute walk, and you just see bread and butter, heart failure, you know, kind of just great bread and butter general medicine, which has made me want to work at the VA. And then also, again, you can take a nice short 5 to 10-minute walk from the VA to our safety net hospital, our community hospital, Penn Presbyterian, which is almost a mix in between HUP, our big academic institution, and then the VA. So we see such a variety of patients, which I feel I've gotten a good exposure to all different pathologies throughout my training.
Yeah, and I'll say, like, you'll hear a lot about like the hospital systems that like residents rotate through, like as you learn about residency programs. But I think one thing that people don't really talk about is like your clinic experience. You know, I think that we have like a few different clinics that you'll rotate through throughout residency. And then you also have like really cool opportunities to rotate at really unique clinics. Like we have a Suboxone clinic, for example, where you can treat a lot of patients with OUD in the West Philadelphia community. I run our refugee clinic, which is like my biggest passion. And it's been such an amazing experience. You know, we're literally like the first stop for refugees and asylum seekers coming to this country. So there's a lot of really cool opportunities that I think are pretty unique that you might not find at other programs. And then, do you guys have morning report at your residency? What is that culture like?
Yeah, I am. So we have noon conference. I know a lot of programs have noon conference and morning report. I wish we had morning report as well, because as you know, being part of this community, the more case conferences, you know, the better opportunities, more opportunities to nerd out with people like you all. But we have a noon conference that is, you know, similar to morning report. A lot of it is, you know, case based. Usually it'll be, you know, like a clinical unknown, and then halfway through, 45 minutes through, there'll be an expert in the diagnosis that was made in the case. And you know, the culture's really great. You know, the residents love to talk through cases. You know, the experts are, you know, world experts and you know, the disease that we're talking about. So it's a very good culture. But yeah, no morning report, but it's mainly a noon conference.
Yeah, Mark actually just gave his all the third years have to do like a third year report. So he just gave his like noon conference, which was very fun.
I presented the case of, I think, yeah, that was was that
histo.
the first case I presented? Yeah, the disseminated histo.
Yes.
I presented that case at a noon conference. It was a lot of fun. And we had one of our ID experts, that was the consultant when I was an intern on the case, come back and be the kind of guest expert on the case.
Do we have teaching opportunities in our program? Definitely a lot of teaching opportunities. There's actually a medical education and leadership track, which Mark is a part of, and I'm sure he can give you more information on that. But just generally, it's a very much like teaching oriented like vibe. So as you become a senior resident in particular, like it's kind of the expectation that you'll be doing teaching on rounds, and then whenever you have downtime with your interns, and we get a lot of education on like how to do formal teaching too, which is great.
Yeah.
Oh my God.
And
we did meet in residency. So I guess that's the best part.
Yes, the first time we met was when it was the first week of intern year, and I was on one of our rotations called subspecialty night float, which is the liver and lung service. And I was so scared because it's one of the sickest services in the hospital. Luckily, I had amazing senior resident who was going into hepatology. But as I was wheeling my first patient, unfortunately, that kind of decompensated on the floor to you in the ICU. That was the first time we met. So essentially in the ICU.
Yes,
and
very romantic.
Yes, and I had no idea what was going on. She's like, "What's the beta-D-glucan? What's the aspergillus antigen?" I'm like, "What are these things? I've never heard of these things." I'm like, "You're definitely interested in ID." And then I could also talk about the medical education leadership track. So that's something that you apply to at the end of your first year. And it kind of starts off after you get accepted to the track as kind of a 2-week intensive, where you kind of learn the foundations of like educational theory, cognitive biases, all those kind of things of, kind of core concepts in medical education, chalk talks, and then kind of leaders in medical education from Penn and even surrounding institutions as well will come in, talk about their experience in med ed and kind of med ed careers. And then kind of throughout the 3 years during residency, we have monthly conferences where we'll talk about, new med ed papers that come out, kind of our struggles, and then also things that we're doing well on in our in med ed and teaching in the hospital. And then we do specific rotations as well as part of the MELD track. So I do a lot of time at the VA, specifically when sub interns are on at the VA. So Penn's kind of unique. I mean, I've obviously only been at Cooper for med school and then, Penn for residency, but from my understanding, it's kind of a unique experience at Penn for the 4th year medical students, where at the VA it's probably like 4 or 5 months throughout the year that there's 2 sub interns, so 2 4th year medical students, which serve as the interns on the VA team. And then there's me. So there's only one technically resident on the team. So it's great for the 4th year med students because they take a lot of responsibility and autonomy as interns at the VA. And then for me, it's just great teaching opportunities because I have 2 really excited and, passionate 4th year med students that are going to be interns next year in internal medicine. So I think that's a really unique experience that we get. And I've probably done that rotation like 3 times, and it's always just a blast.
Amazing. Thank you so much for answering our questions. I had to ask how you guys met each other because I was curious. I love a love story. And yeah, was a really great session. I really want to thank Mark. I invited him and then he answered me super fast and said, "Yeah, let's do it. We are super excited." And was a really pleasure to have you both here. Tara, you are welcome to come back. We would love to see you here on VMRs. And this is the first program that we receive. And if anyone want to join us, we are gonna have a few more programs coming the next Saturdays. And so if anyone want to join us, please, you can contact me and yes. So yeah, thank you very much, everyone. And I hope to see you all tomorrow.
And guys, I'll just say too, if you have any more questions about Penn, because I know residency and the process and everything is very complex. So please message me on WhatsApp. I'm happy to, take any additional questions, even like calls, Zoom, anytime you guys want to talk about residency and Penn as well. I'm happy to chat with you guys.
Yeah,
Thank you,
same.
Mark.
Thank you guys so much.
Bye
Thanks,
bye.
Mark. Thanks, Mark. Thanks, Uthara. Great to see you both.